definition for MDR and XDR. So this is a study on using the expert XDR, where you can see the sensitivity to INH and fluoroquinolone is all above 93%. This is the result of another study in 2022, where it can detect INH resistance. So it can detect the true MDR cases, not only the surrogate marker like the previous MTB-RIF. It can also detect resistance to fluoroquinolone. That means it can detect pre-XDR cases, and it detects injectable second-line drugs like aminoglycoside. So as per the previous definition to 2021, it was actually meant for definition XDR of those periods. So the second line injectable drugs. So what are the changes in the definition is actually, we have now pre-XDR, which is MDR plus resistant to any fluoroquinolone, whereas MDR, as we know, resistance to rifampicin and INH, and pre-XDR in addition to that is resistant to any of the fluoroquinolones, and XDR is pre-XDR along with the resistance to either bedaquiline and linezolid, because now the treatment regimen for has totally changed to all oral drugs like bedaquiline and including bedaquiline and linezolid. So second line injectable drugs has been removed from the definition of XDR. Now, who should be tested for drug-resistant TB? As per the WHO recommendation, the use of the approved rapid and molecular DST as the initial test to detect drug resistance before initiation of appropriate therapy for all TB patients, including new and patients with a previous history of TB treatment. So these all platforms, as I discussed, are the WHO approved molecular diagnostic tools for TB and DRTB. And these are the classification according to the complex technical complexity has been divided as low, moderate, and high by WHO. Now, moving on to the recent advances, that means the test I'm going to discuss is which are not yet WHO approved or implemented. Some of this, of course, has been WHO approved. I'll come to that. So almost majority of them are in pipeline because the result is appearing quite promising. Now, first, starting again from the smear microscopy, it's a very interesting studies are going on. This is a staining which can detect the viable staining of Mycobacterium tuberculosis by using the stain fluorescein diacetate. Now, how this acts, this stain is when passed through the hydrophobic cell membrane of the viable mycobacteria. This gets rapidly hydrolysis by the enzyme cell esterase, which are present only in the live metabolically active bacteria. Now, so this gets accumulated in the cytoplasm because of the intact cell wall. So when it views under the fluorescent microscope, the live bacilli you can see in the picture appears as yellowish green fluorescence, and the dead bacilli, they lack functional acetyl esterase activity and they do not fluorescence and appears red. Now, this is a study where you can see the sequential picture before the start of treatment at the end of first, second, and fourth week. You can see the fluorescing yellowish green is gradually decreasing, and the red color bacilli are gradually increasing. So this can be used to predict the culture positivity, whether patients are responding to TB treatment or not, or it's an indicator of drug resistant strain. Now, moving on to the point of care test. Now, in this, what we have is again another model of gene expert system, which is called Omni system, Gene Expert Omni. This can accommodate only one cartridge and can be battery operated. So, because it can be battery operated, it can be done at the very remote area where even this Gene Expert MTB-RIF cannot be done. This result, what I have shown here in this table, basically tells that this result is non-inferior to MTB-RIF. This has been compared with RIF Ultra, and it was found that very minimal discordant results are there. Now, there is another system is coming up, or various studies are there, which is called EasyNat MTC assay. This is basically a novel LAMP system. This is based on cross-priming amplification using specific primers, and single cartridge used for extraction, purification, and amplification and detection. Now, basically, you can say similar to LAMP system, having isothermal amplification. But so this picture I'm showing just to give you the impression that the multiple primers are there and the cross linking is happening as it happens in the LAMP system. That though technically it is quite complex, I'm not going to the technical complexity. This is just to give you the impression how the cross priming appears. And the result of various studies, it shows that in smear and culture positive, both expert and EasyNat detected all the cases, whereas in smear and culture negative cases, in fact, it yielded more than expert in this study, though of course it doesn't detect drug resistance. Now, if you see another study in children using gastric aspirate, you can see the discordant, the left and right side number is quite high. That means the discordance is still there. So this system appears it needs further improvisation to come to at par of expert system using various clinical specimens. Now, moving on to MALDI-TOF. Now, we all use, many of us in microbiology lab, MALDI-TOF is used. Now, here, it is not the simple MALDI-TOF, it is nucleotide MALDI-TOF MS in the rapid diagnosis of pulmonary tuberculosis and drug resistance. There are various studies have come up recently in 2023 and 2024. Now, this is again like nucleotide MALDI-TOF assay. This is nothing, in this assay, actually what they have done is, it's an integration, the sensitivity of PCR technology and mass spectrometry. Both the techniques have been merged. So it has 6 steps, like extraction followed by PCR, then the purification by using the enzyme, then extension, detection on the mass spectrometry instrument, and automated analysis. Now, here we have to remember that this is using a different platforms of MALDI-TOF. It is not the same what is used for this MALDI-TOF in most of the microbiology labs. So these are the result of these various studies using the nucleotide MALDI-TOF assay. If you see the first, I have kept it in the box. The accuracy we can see near 100% as compared to the phenotypic drug sensitivity. The lower table again as compared to expert MTB-RIF, where the sensitivity and of nucleotide MALDI-TOF as compared to expert MTB-RIF has been shown to be higher. And there's a graph you can see that is in comparison to the, or taking the clinical as the reference point. You can see the red line is higher as compared to the midget culture. So this is as compared to culture. Again, it is showing a better result. So this also appears, the result appears quite promising, but this nucleotide MALDI-TOF is, I think, restricted to fewer manufacturer and not yet come to the market. I'm not very sure, but probably it has not come to the market because it is used by various fewer mix. Now, moving on to another system, which is microarray based system for detection of first line and second line. Again, like many other systems, it has multiple steps, starting from a sample lysis and homogenization, followed by extraction, purification, PCR amplification and hybridization, and finally the array imaging and analysis. This is also why I'm saying this appears promising. I'll show the result also. Now, this test actually, this type of similar tests are there from various manufacturers. Of course, I got the literature from one of the particular manufacturer in maximum number. This system they have been trying since almost last 15 years, and with gradual improvisation in the technique to get a better yield, better in sensitivity and specificity, they have come up to this level where the final analysis is done by array imaging and analysis. Now, various studies have come up mainly using this Aconi biosystem. These are the various genes detected. Now, if you see the result, the first one tells the sensitivity specificity against phenotypic DST. Now, WHO has a target product profile. That means the criteria has to be fulfilled by the system to get the approval of WHO. Now, here we can see the INH and rifampicin are fulfilling the criteria, though the fluoroquinolone and amikacin are still lagging behind. Whereas specificity, they all are fulfilling the criteria. But at the same time, if we see as compared to the whole genome sequencing, all are giving very good confidence with various drug resistance detection, around 95% or more than 95% confidence is there. So it appears quite promising, and maybe in near future we can have this in market. Now, what are the limitations of this molecular drug resistance testing? Be it any test, there can be false negative and there can be false positive as well. Now, where it can be false positive for resistance detection, where the mutation occurs outside the target gene. For example, if it is outside RRDR of RPOB gene for rifampicin, the system will give a resistance not detected. That means the resistant mutation in other than the target gene. So what all target genes are there, it's very important to know, and at the same time what a type of mutation needs to confer the resistance. Now, false positive can occur where there is a silent mutation. Mutation is there, but it is not responsible for conferring the resistance. So these challenges are there, challenges of missing resistance, discordant results between phenotypic and molecular, between any two molecular tests, detection of heteroresistance, handling the false positive and false negatives. So what is the solution? The ultimate solution of all these problems are nothing but sequencing. Now, sequencing, if we see for Mycobacterium tuberculosis, it can be target NGS or it can be whole genome sequencing. Now, there are definitely advantages and disadvantages of both. In target NGS, the specific target are targeted or sequenced, whereas in whole genome sequencing, it is, as the name suggests, the full genome is sequenced and no specific target is sequenced. Target NGS, it can be done directly from sample or from culture isolate, whereas WGS require a culture isolate. Target NGS and WGS both can detect rare mutation and heteroresistance. That's a very good aspect of this sequencing system, be it target or whole genome, because as we are moving towards elimination, we need to actually detect rare mutations and can pick up even the single resistance cases. And this is where the sequencing plays a very big role. Now, target NGS is definitely less expensive as compared to WGS, and it includes a simpler bioinformatics as compared to WGS. Of course, though less information is there in target NGS as compared to WGS, but at the same time, we must understand that if we can include the important targets or the clinically relevant targets, the target NGS can really give us the clinically relevant solution to find out more and more cases of drug resistant cases. Now, in the target NGS, again, there are many manufacturers are coming up. This Diplex MIC-TB by Genoscreen is one such, where it shows resistance to 13 anti-TB drugs. Now, because it's a sequencing system, it is not only can detect drug resistance, but it also use typing method for detect the species, and identification of 140 microbacterial species also can be done. And the turnaround time is less than 48 hours. It is highly sensitive. It can predict more than 97% of this resistance phenotypes, which can be detected by WGS, and can detect heteroresistant subpopulation as low as 3% of bacteria. And the results have been shown in various clinical studies. Here in the box, red box, you can see it has included the newly included drug like bedaquiline, clofazimine, and linezolid. So it can give us whatever drug we are using these days for treatment. It can also give result or the mutation status of these drugs as well. So this has already been marketed by Illumina and Genoscreen Dplex MTB combo kit. And various studies, these recent studies have come up, which is showing very promising results. Now, if we see this recent result of a recent study published in October 2024, accepting ethambutol and ethionamide, all the concordance with when compared with WGS, you can see all other drugs, it is near 100% concordance is there. So these are like the coming up tests. Maybe we all can see this in coming near future, like test like EasyNat, or test like lateral flow XTR or nucleotide mildit of MS, and particularly the sequencing and particularly the target NGS can come up as benchtop device and can be there and the benchtop of clinicians also. So target NGS is definitely besides other tests, target NGS is definitely appears to be very promising test, which we can see because it's already been there. We can see in the near future, and maybe we all will be using this target NGS in very near future. But still, we have a long way to go, both in diagnosis of MTB as well as in the detection of drug-resistant TB. In particularly in diagnosis, we still struggle to diagnose all the EPTB cases, particularly TB meningitis, the bone and joint TB and GI TB, and the possibacillary cases like TB in children and HIV cases. And resistance, of course, as I said, the newer drugs should be implemented, and along with INH and fluoroquinolone, which all are now in the treatment regimen by simple, accurate, and affordable method. So with this, I'll end here. Yes, we can end TB, commit, invest, and deliver, the theme of this year's World TB Day. Thank you so much.
Thank you, ma'am. That was very informational. Participants, you can ask any questions right now.
Thank you, Virasman. It's always a pleasure to listen to your lecture. There are few questions, ma'am. Especially in rural settings where microscopy is still the main diagnosis, is there anything can be done to implement molecular testing in these areas, especially when there is power limitations?
Yes, as I said in the POCT, the Gene Expert Omni is coming up, that battery operated system having almost equal result with Expert MTB. So that is that appears to be, we can see in the remote test of remote area, it doesn't need any power, it can be battery operated. So that's the molecular test which can be done.
The next question is, ma'am, what about the mutations which occur outside this 81 base pair? How do we go about it?
Is that for rifampicin resistance? Yes, yes. So actually, WHO has come up with a catalog showing the different genes where the mutation which confers resistance and the exact mutation. So in this, after that has come up, various manufacturers, they have started including those genes as well. We know that RPOB gene confers most of the resistance, but not 100%. That is why we miss the rifampicin resistance. So if we include include, or if the system can include maximum number of those genes which may be rarely conferring resistance, but they are there. So those type of systems can detect this resistance or occult resistance, we can say.
And the next question is what many are facing is the discordance between the TrueNAT and the gene expert. Even RIF resistance and also the MTB positivity rate, there is a slight discordance between. So how, in these situations, what would be the best scenario to go about?
Yeah, that's a very difficult question. Even we found in our lab, and we don't know what exactly is the answer. Because if we see the limit of detection wise, TrueNAT claims to be like the limit of detection is lower, or the sensitivity is higher in TrueNAT as compared to CBNAT. But in practice, we really have to compare that, or the final solution is practically we cannot do comparing, because we cannot assume that CBNAT is better or TrueNAT is better. The ultimate solution is sequencing in those cases, which I understand is difficult to do, but maybe by the system where they can go for both rifampicin or ionate resistance, but it's really a practical problem. I understand that.
The other question is, ma'am, which would be the diagnostic tests which can be used for genitourinary TB detection?
Yeah, genitourinary urine is the sample. Previous to 2021, WHO has not recommending urine sample for testing, but in 2021 manual, the students can go through that manual. It's an excellent manual where all the newer things have been added by WHO is there. So urine is now an accepted sample for CBNAT, so that can be subjected for testing. And in fact, when we started implementing urine sample, we are getting a lot of cases CBNAT positive, and they're clinically relevant. So that can be done. Urine is the sample.
The delegate is asking, ma'am, what would be the biosafety level which can be used for microarray testing?
Wherever we are handling sample, it's not microarray or any other molecular test. By that time, we have already lysed the sample. Once we lyse the sample, it is considered as non-infectious. So wherever we are handling the sample, that is the biosafety cabinet class A2 or B2 is required. So that has to be there.
Ma'am, the other question is, can mRNA can be used as a marker of viable TB?
mRNA.
RRNA or mRNA?
Okay, theoretically it appears okay, but unless the studies have come up with such result, it's very difficult to give any comment on that.
There was few have occurred an incidents where culture was positive, but gene expert was negative. So what could be the reason which can avoid these situations?
Culture is positive, gene expert is negative for detection
Of TB.
or for rifampicin resistance.
No, ma'am, MTB.
MTB. So in that case, it can be NTM also. So we have to rule out whether it is non-tubercular mycobacteria or not. So if it is not NTM, then we have to, then it is MTB complex. That can happen in very rare cases, particularly with the very low bacterial load. Recently, we encountered one case where it was first sample was CBNAT negative, then it came positive in culture. Then when we subjected it to LPA, line probe assay, it showed, in fact, we had subjected it for this NTM speciation, thinking that it is NTM, but it came out to be MTB complex. So in a very low load, it can happen, but before that, we have to rule out NTM.
Thank you, ma'am. There are still questions and also many thank you pouring in the chat. And
thank you so much. Thank you.
We'll end the question answer session here. Thank you very much, ma'am.
Yeah, thank you. Thank you so much.
Thank you, ma'am. Okay, we will be moving towards the last session of the day. Please let me buy some time to check if the speaker is logged in.
They're not giving break.
So to the last session of the day, I request Dr. Vishnu Vandana, Professor, Department of Microbiology, to present the speaker, Dr. Devanathan.
Very good afternoon to everyone. It is my prestige to welcome and introduce Dr. V. Devanathan. Dr. V. Devanathan is presently working as a consultant pulmonologist at Hindu Mission Hospital, Chennai. He has been a former nodal officer for drug-resistant tuberculosis at GHTM Tambram, which is a recognized center of excellence for drug-resistant TB. He has specialized in asthma and tuberculosis with focus on drug-resistant TB and has over 7 years of experience in treating multi-drug resistant and extensive drug-resistant TB using advanced regimens including bedaquiline and delamanid. He has credit of undertaking CME programs from Harvard Medical School and has done clinical HIV management course from University of Washington. He has presented multiple research papers at various state and national conferences. Sir, it is a pleasure to have you with us and we welcome you for today's CME. Kindly request you to speak on the treatment of drug-resistant TB, newer regimes and challenges. Thank you.
Hello, am I audible?
Yes, sir.
Yes, thank you. Thank you for those kind words of introduction. At the outset, I'd like to thank the organizers for giving me this opportunity. Today, we'll be discussing about what are the latest treatment guidelines in the management of drug-resistant tuberculosis. I'll be sharing my screen now. Just a second. Is the screen visible?
Yes, sir. Yes, sir.
So today's talk is basically on how to treat a drug-resistant TB case. So as we all know, India is one of the high burden cases for drug-sensitive and as well as drug-resistant TB cases. So we have a global commitment to end TB, and India is also committed to end TB by 2025. So first, we should know what causes tuberculosis. Tuberculosis is caused by Mycobacterium tuberculosis. It predominantly affects the lungs, but can affect any part of the body except for the hairs and nails. So it's spread by coughing out of the sputum from one person to another through aerosol dispersion. What are the signs and symptoms? If patient comes with these 4 symptoms, you should be aware. So for pulmonary TB, the patient will be complaining of cough of more than 2 weeks duration. He might have loss of weight and loss of appetite. There will be an evening rise of temperature along with hemoptysis and night sweats. The 4 classical symptoms is cough more than 2 weeks, loss of weight and appetite, evening rise of temperature, and hemoptysis. If this symptoms is present or if the patient is having an immunosuppressed state, so the commonest immunosuppressed state that we see is diabetes mellitus. Other immunosuppressed states such as HIV or renal transplant patient or renal disease patient or any immunosuppressive disease or autoimmune disease who are on methotrexate or any other immunosuppressants, you should suspect tuberculosis in this set of patients. Here I've shown an image of cavitary tuberculosis. So what the infection does is it spreads through aerosol route, and in the lung, as you can see, it puts a hole in the lung. The cavity that you see is literally a hole in the lung. So with regards to drug-resistant TB, this is for drug-sensitive TB, what I was saying. Whom do we suspect drug-resistant TB? So you started the patient on a drug-sensitive regimen, but the patient is not clinically improving. His symptoms has not resolved, his weight is not gained, he's still having the symptoms, then you should suspect drug-resistant TB in this set of patients. And drug-resistant TB is comparatively higher in those who have already taken TB and they have relapsed with TB. So first time they have completed treatment. Again, if they are getting tuberculosis, you should suspect the incidence of drug-resistant TB is anywhere between 20% in this subset of patients. And those patients who are in contact with drug-resistant TB patients. And pediatric TB who are non-responding, and those who are failed treatment with first-line drugs, you should suspect drug-resistant TB. So with regards to diagnosis, we have various diagnostic methods. We have the sputum microscopy and fluorescent microscopy. We have, is the pointer also visible? The cursor? So we have the sputum microscopy. We have the solid culture. We can see the rough, trough, and bruff colonies. So we should know the difference between sputum, smear, AFP. If smear means they'll be checking in the microscope for the smear. With regards to culture, there are two types. One is the solid culture where we can see the rough, trough, and bruff colonies. The other is the liquid culture. In the liquid culture, you can see the growth in midget. This is Mycobacterium growth indicator tube. There will be fluorescence if there is growth. This is known as liquid culture. And from this, they'll do drug sensitivity testing. This is to indicate whether growth is there or not. If the culture is showing growth, then they'll detect whether the drug is sensitive or not based on the culture, whether if the culture is positive. Then we have our NAT, that is a nucleic acid amplification test. We have the gene expert and the line probe assay. So we have the sputum smear, we have the culture, and we have another two NAT testing, that is the gene expert and line probe assay. These are the various methods along with your chest X-ray and CT scan to differentiate between the various diagnostic methods. So we should know the first basic difference. So your gene expert, your NAT, that is the nucleic acid amplification test, and line probe assay or PCR based methods, that is polymerase chain reaction. It is known as DRT, drug resistance testing. It's based on genotypic testing. So what gene expert does is it will tell whether MTB is detected or not, and whether rifampicin, if MTB is detected, whether rifampicin is sensitive or not. The advantage with line probe assay is, in addition to rifampicin, we can also know whether isoniazid acid is sensitive or not. So all drug sensitive patients should be subjected to first line LPA also. In addition to gene expert, what line probe assay gives us the additional information whether isoniazid acid is resistant or sensitive. With regards to second line LPA, it's usually run for drug resistant patients. It is to test whether your fluoroquinolones such as levofloxacin and moxifloxacin is sensitive or not, and your injectables. Injectables we are no longer using, such as aminoglycosides are at the end of the spectrum. So basically, second line LPA is done to detect whether levofloxacin and moxifloxacin, your fluoroquinolones, is sensitive or not. These two, NAT and line probe assay or genotypic testing, it should be mentioned as drug resistance DRT. Whereas your cultures are known as phenotypic testing, such as your liquid culture. Liquid culture is most commonly used. Midget culture is the most commonly that we use in our practice. So this is known as phenotypic testing, where we see the growth, and then based on if growth is there, the advantage is we can test the sensitivity pattern of all the first line and second line drugs. So isoniazid, rifampicin, ethambutol, pyrazinamide, all your bedaquiline delaminate, the testing can be done via drug susceptibility testing in culture. This is the phenotypic testing. So the advantage with gene expert is the turnaround time is 2 hours. LPA is around 72 hours. Liquid culture, we can get the growth in 42 days. Liquid culture is what we commonly use. Whole genome sequencing is still not been approved in the guidelines. But the main advantage with whole genome sequences, as in liquid culture, we can get the sensitivity pattern for all the drugs, but it will take anywhere, but it's still not been approved in the guidelines. So for the definitive management, midget culture is the gold standard test. We'll get the report, but the disadvantages will be getting the report in 42 days. But the advantage is we can get the sensitivity pattern of all the drugs, first line and second line. So this algorithm is most important. With regards to treatment of drug resistant, drug susceptible and drug resistant testing, we have only one regimen for drug sensitivity testing. That is your HRZD. We give 2 months. If a patient is drug sensitive TB, we give 2 months of isoniazid, rifampicin, pyrazinamide, and ethambutol. The 4 drugs for 2 months. And another 4 months, we give 3 drugs only: isoniazid, rifampicin, and ethambutol. This is the drug sensitivity regimen. With regards to drug-resistant regimen, you can see there are 4 regimens, 4 standard regimens. The first is the isoniazid monoresistant. If isoniazid alone is resistant, instead of isoniazid, we replace it with levofloxacin. The rest of the 3 drugs such as rifampicin, ethambutol, and pyrazinamide is the same. There's no intensive or continuation phase. This is also a 6 months regimen. So if the first regimen is drug sensitivity regimen, with regards to drug resistant, the first regimen is isoniazid monoresistant regimen. That is the 6 months of levofloxacin, rifampicin, ethambutol, and pyrazinamide. With regards to, this is isoniazid monoresistant regimen. With regards to MDR, we have 3 regimens. One is the newly launched 6 months BPAL-M regimen. This is bedaquiline, pretomanid, linezolid, and moxifloxacin. Here we are giving 4 drugs for 6 months. So this is the first regimen. If the patient is not eligible for this, then we have 2 more regimens. One is the shorter oral regimen. This is a 11 months regimen. This will contain 7 drugs in the intensive phase and 5 drugs in the continuation phase. So for MDR, the first regimen is BPAL-M. This is given for 6 months. If the patient is not eligible due to any cause, then we move on to the shorter MDR regimen, which is a 11 months regimen. This contains 7 drugs in the intensive phase and 4 drugs in the continuation phase. If the patient is not eligible for the shorter MDR regimen, the 11 months regimen, the patient will be pushed to the longer MDR regimen. Longer MDR regimen contains of 5 drugs only in the intensive phase and 4 drugs in the continuation phase. This is a 20 months regimen. So for drug-resistant TB cases, you should know 4 regimens. One is isoniazid monoresistant regimen. The next is, with regards to MDR, we have 3 standard regimen. One is a 6 months regimen. That is the BPAL-M. We have 4 drugs for 6 months. If patient not eligible, then we give the shorter MDR regimen. That is for 11 months regimen. If the patient is still not eligible for the shorter MDR, then we move on to the longer MDR regimen, which is a 20 months, nearly 2 years that this regimen will be there. So you need to know the classification of TB. So when you write the case sheet, you should write whether it's pulmonary or extrapulmonary TB. The second part, what you should write is whether it's a drug-sensitive TB or a drug-resistant TB. The third part, what you should write is whether it's microbiologically confirmed. The test that I have shown, like all these methods are microbiologically confirmed methods. Your sputum smear or your culture or your NAT, either gene expert or LPA, these, if you get a diagnosis through this, then it is microbiologically confirmed TB. If it's clinically diagnosed based on history, such as cough more than 2 weeks or evening rise of temperature with loss of appetite, or radiological features of cavity, infiltrates, or miliary pattern, or if the histology is classically showing caseating granulomatous inflammation, then you have to term it as clinically diagnosed. Only if it's diagnosed via sputum microscopy, gene expert, or LPA, or culture, you should term it as microbiologically confirmed. So your diagnosis of tuberculosis patient should contain 3 parts, whether pulmonary or extrapulmonary, whether it's drug sensitive or drug resistant, and the third part is whether it's microbiologically confirmed or it's clinically diagnosed. I'll be sharing the PPT. So listen for the talk along. So for the drug sensitive pattern, we should know why we are giving this regimen. So for drug sensitive TB patients, you will be giving 2 months of HRZD and 4 months of HRE, that is isoniazid and rifampicin and ethambutol. Only pyrazinamide we are not giving in the continuation phase for 4 months. Why we have followed the previous regimen was 2 HRZD and 4 HR. The government has now added ethambutol in the continuation phase also. This was implemented from 2018 onwards. Why we have done is that when primary isoniazid resistance is high, if isoniazid is resistant and if LPA line probe assay is not done, we won't know the status of isoniazid. And in India, isoniazid resistance is quite high. So we have added ethambutol in the continuation phase. If isoniazid is resistant, and if we are giving this regimen, you can see we'll be giving a single drug only, rifampicin only. In a lot of places, we still don't have the facility to check whether line probe assay facility is not there, and they're not checking the sensitivity pattern of isoniazid. So if isoniazid is resistant, then if you give the earlier regimen, we'll be giving a single drug in the continuation phase. In order to prevent that, we are giving an additionally ethambutol also in the continuation phase. So this is for drug sensitive treatment. The first regimen is drug sensitive pattern, 2 months of HRZD and 4 months we give HR and E. This is an India specific regimen. So we need to know how the drugs are being given. So this is known as fixed dose combination. So each of the drug will be containing 75 mg of isoniazid, 150 mg of rifampicin, 400 mg of pyrazinamide and 275 mg of ethambutol. Each of the pills will be having all the 4 drugs. So fixed dose combination. According to the weight band will be given in the intensive phase, since 4 drugs are there, we'll write 4 FTC, and the continuation phase only 3 drugs are there, we'll write as 3 FTC. So according to the weight band, this is the red color strip that you see is the intensive phase. The green color strip you see is the continuation phase. Here each tablet will have all the 4 drugs, HRZD, 75 mg of isoniazid acid, 150 mg of rifampicin, 400 mg of pyrazinamide, and 275 mg of ethambutol. All the tablets will be having. According to the weight band, we'll be writing 2 OD, 3 OD, 4 OD, 5 OD, according to the weight band. So if the patient is say 35 kg, he'll be writing 4 FTC, 3 OD. In the red strip, you have to give 3. Again, when after 2 months, when he goes to the continuation phase, in the 3 and the green strip also, you have to give 3 tablets. Here, it will have only 3 drugs. So we have to write it as 3 FTC in the continuation phase. This is the drug sensitivity regimen. So if the patient, you have started this on the drug sensitivity regimen, when do you suspect drug resistance? As already told, you have started drug sensitive pattern, and if you're seeing the patient is not responding properly, then you should suspect drug resistant TB. If the patient is poorly compliant or not taking the drugs properly, then there's a high chance of him lining up with drug resistance. You're given a drug sensitivity pattern, should know what all conditions in which he will be, in spite of giving the drugs, he is not responding properly. One is poor compliance. In India, a lot of patients don't take the treatment for 6 months. So in spite of adequate counseling and all, if the patient misses the drugs, there's a chance of patient not being termed as failure. The patient will not respond, not adequately get treated. So poor compliance, then it can be a drug resistant TB. So you are giving a drug sensitive regimen, but the patient can be having a drug resistant, either an MDR or isoniazid resistant TB. In certain cases, the other alternative is poor drug absorption. In the abdomen, the intestine, the drug absorption might be poor. Or if you, in spite of giving your TB tablets, the patient is not responding to treatment, you should suspect alternative diagnosis such as the common close differentials to tuberculosis are non-mycobacterium tuberculosis, sarcoidosis, melioidosis, or nocardiosis. So with regards to DR-TB, we have four terminologies you should know. What are the types of drug-resistant TB we have? One is the isoniazid monoresistant TB. So for HRZD is the 4 first-line drugs. Here, isoniazid is resistant. So instead of isoniazid, we replace it with levofloxacin. This is a 6 months regimen we give for isoniazid monoresistant TB. For MDR-TB, now we have 3 regimens. One is the 6 months BPAL-M regimen. The second is the short, that is a BPAL-M is 6 months regimen. Second, we have a shorter duration of 11 months regimen and a longer duration of 20 months regimen. Next, we need to know what is pre-XTR and what is XTR. The terminologies you should know. We have a term known as universal DST. For drug-resistant TB, if the patient has been diagnosed based on sputum smear, all drug-sensitive patients should be subjected to gene expert. So at least rifampicin status, you should know whether it's sensitive or not. This is for drug-sensitive TB. And with regards to drug-resistant TB, further second-line LPI at least should be done to know the status of fluoroquinolone. Whether moxifloxacin is or levofloxacin sensitive or not should be done. This is universal DST. This you should be know. So for drug-sensitive TB, all patients should be tested for rifampicin, whether it's sensitive or not. And with regards to DR-TB, fluoroquinolone sensitivity must be known. So the terminology for MDR is multi-drug resistant TB is those TB patients whose biological specimen is resistant to both isoniazid and rifampicin, with or without resistance to additional first-line drugs. Pre-XTR TB is your MDR-TB, that is isoniazid and rifampicin resistant. If they are further resistant to fluoroquinolone, it's termed as pre-XTR TB. Then XTR TB is your pre-XTR TB, that is resistance to isoniazid, rifampicin, and fluoroquinolone in additional resistance to bedaquiline or linezolid is known as either bedaquiline or linezolid is known as XTR TB, extremely drug resistant TB. So these 3 terminologies you should know. MDR is isoniazid and rifampicin. Pre-XTR is MDR plus fluoroquinolone resistance is pre-XTR. Pre-XTR plus additional resistance to either bedaquiline or linezolid is your XTR TB. We have a grouping of drugs according to WHO classification. Group A contains of your fluoroquinolone, that is levofloxacin, bedaquiline, and linezolid. So the resistance that we term is based according to this group. So MDR plus your levofloxacin is known as pre-XTR. Resistance to either levofloxacin or moxifloxacin. Pre-XTR plus additional resistance to either bedaquiline or linezolid is known as XTR. So MDR plus levofloxacin, pre-XTR. Additional resistance to either bedaquiline or linezolid, you term it as MDR-TB. So 3 drugs we have in group A, levofloxacin, bedaquiline, and linezolid. Group B, we have 2 drugs, clofazimine and cycloserine. So while forming the regimen, we usually for the longer regimens, for a 20-month regimen, we take 3 drugs from the group A and 2 drugs from group B. Ideally, 5 drugs should be there. So levofloxacin, bedaquiline, linezolid, clofazimine, and cycloserine. If either one drug could not be given due to any drug intolerance or drug resistance, we substitute with group C. So group C, at least group A and group B, you remember. Levofloxacin, bedaquiline, linezolid is group A, clofazimine and cycloserine is group B. Rest of the drugs are group C. So group A, group B is easy to remember. These 5 drugs you remember. Levofloxacin, bedaquiline, linezolid, group A, clofazimine and cycloserine. This is how we form. If we are not able to form a regimen with these 5 drugs, we go to group C. This is for 20 months regimen. So the standard regimen, we have 4 standard drug resistant regimen. One is your isoniazid monoresistant. That is, isoniazid is resistant. We replace isoniazid with levofloxacin, and we continue the rest of the other 3 first line drugs such as rifampicin, ethambutol, and pyrazinamide, and we give it for your 6 months duration. For MDR, that is your resistance to rifampicin and isoniazid, we have 3 regimens. One is the BPAL-M. We have 4 drugs over here: bedaquiline, pritonomide, linezolid, and moxifloxacin. We give it for 6 months duration. The shorter MDR is a 11 months regimen, and the longer MDR is a 20 months regimen. This is what I told. The 20 months regimen, how we frame is, we take 3 drugs from the group A and 2 drugs from group B. This is the longer MDR regimen for 20 months. So you're diagnosed a drug resistant TB based on your gene expert and your line probe assay. So what all we do is, we clinically first get the height and weight of the patient. We see the chest X-ray for radiological assessment. We get the chest X-ray of the patient or CT scan. Then thirdly, with regards to blood parameters, what we do is CBC, LFT, RFT. So CBC to check whether how much is the baseline hemoglobin and white blood cells and platelets. Liver function test to check whether a patient is having any pre-existing liver disease, and renal function test we do. For 2 diseases, we have bidirectional screening. One is HIV. So all TB patients must be screened for HIV testing, and for diabetes. So all TB patients will be screened for HIV and diabetes. So fasting postmortem and HbA1c will be done. Radiological assessment, we need to know whether the patient is clinically improving from the baseline X-ray to follow-up X-ray. Then this is common for drug-sensitive TB also. What I have highlighted over here is specific for drug-resistant TB. For drug-resistant TB, you should do electrolytes. If any electrolyte abnormality is pre-existing, we should correct it. Your calcium, magnesium, and all you should assess before itself. And if any pre-existing electrolyte abnormality is there, we correct it beforehand. Certain drugs are known to cause QT prolongation. Your newer drugs such as bedaquiline, dilamide are known to cause QT prolongation. The other drugs that can cause QT prolongation are moxifloxacin and clofazimine. So based on ECG should be done. If any pre-existing arrhythmia or any heart disease is found, you should get a cardiologist's opinion beforehand before starting your regimen. And you should also take an ECG to check the QT interval. So cardiologist's opinion is better. If any abnormality is found on ECG, you should get a cardiologist's opinion, since the newer drugs such as bedaquiline and dulaminate can cause QT prolongation. Ophthalmologist's opinion we get because we add ethambutol and linezolid. Both can cause optic neuritis. So ophthalmologist's opinion must be got before starting the regimen. We do a baseline thyroid profile also. And in females of reproductive age group, we should do an urinary pregnancy test because these drugs are teratogenic. And you should know whether the status of the female patients in the reproductive age group, whether they are pregnant or not. So pre-treatment evaluation must be done. It's valid for only 1 month. This is before starting the regimen, the pre-treatment always should be done within 1 month of starting the regimen. With this only we'll start the regimen. So all this investigation should be within 1 month from the date of starting the regimen. If not, we should repeat it again without 1 month. So as I already told, before starting the regimen, you have found the patient as drug-resistant TB. We are now going to start the treatment. Before starting, we should know the history, what all complaints the patient had. Weight we should know. Ophthalmologist's opinion we should know. If cardiologist's opinion is only required if there's any pre-existing arrhythmia or cardiac disease is there. Certain drugs are known to cause psychiatric disturbances. If any pre-existing psychiatric disease is there, we should also get a psychiatrist evaluation if required only. But the ophthalmologist's opinion, weight, and the patient's height, weight, and you should know beforehand. And with regards to blood investigation, CBC, LFT, RFT is common. For 2 diseases, we have bidirectional screening. One is HIV and another is diabetes. So both the testing should be done. electrolyte abnormalities should be done, and for urine pregnancy test and baseline radiographic assessment should be there, chest X-ray and or CT scan. So as already told, isoniazid acid resistance can be found with first line LPA, line probe assay. First line will give the first thing with the, it will tell first line LPA, the report will be MTB detected, isoniazid acid is resistant, rifampicin is sensitive. So rifampicin is sensitive and isoniazid acid is resistant. In only that case, we give isoniazid acid is resistant. We replace the first line isoniazid with levofloxacin. Rest of the three drugs is same. There is no intensive phase, no continuation phase. Isoniazid acid is resistant, simple regimen. HRZD in H is resistant, we replace with levofloxacin. Rest RZD remains the same. It's a 6 months regimen. So this is how 6 months isoniazid acid is resistant. We replace it with levofloxacin. This is the weight band. 16 to 29 kg is one weight band. 30 to 45 is one weight band. 46 to 70 is one weight band, and more than 70 is one weight band. So for all drug resistant TB, we have this 4 weight bands. Say if the patient is 50 kg, we'll follow the third weight band. We'll give 600 mg of rifampicin, 1200 mg of ethambutol, 1750 mg of pyrazinamide, and 1000 mg of levofloxacin. So according to which weight band the patient falls, it's easy to give. Levofloxacin is resistant, so isoniazid acid is resistant, so we replace it with levofloxacin. This is known as isoniazid monoresistant regimen. It's usually given for 6 months. If the sputum smear at the end of 4 months is positive, then they might extend for 9 months also. But you remember, it's a 6 months regimen. If isoniazid acid is resistant, you replace it with levofloxacin. Simple regimen. According to weight band, you're going to give the regimen. So this is simple. So if certain drugs cannot be given, we have a replacement sequence. This is not not needed as of now. Given in the PowerPoint. If not, you can go through later. So with regards to isoniazid acid monoresistant regimen, I just want you to know it's 6 months regimen. Isoniazid acid is resistant. Then so we replace it with levofloxacin. Rest of the 3 first line drugs remains the same. We give it for 6 months according to the weight band. This is the most commonly given regimen. Okay, for isoniazid acid resistant regimen. So the next regimen, what we are now coming is your MDR-TB. MDR-TB, you need to know 3 regimens. Now, this is the recently introduced B-PAL-M regimen. It's a 6 months regimen. It can be given for only for age above 14 years. So you give 6 months, 4 drugs, simple. So no intensive phase or continuation phase. So we give bedaquiline for 6 months, predominant we give for 6 months, linezolid we give for 6 months, and moxifloxacin we give for 6 months. So 4 drugs we give. So we'll see what are the inclusion criteria in MDR-TB. So this will be the first regimen that we are giving for MDR-TB. We'll see the inclusion criteria and for which all patient we cannot give this regimen. So if the patient is not suitable for this regimen, then we have to go for the shorter 11 months regimen or the longer 20 months regimen. You see 3 regimens are there for MDR. One is 6 months. The next is a shorter regimen, which is for 11 months. The longer regimen is for 20 months. Okay. Here, no intensive and continuation phase. We give 4 drugs, bedaquiline, predominant. Both these 2 drugs are newer drugs, bedaquiline and predominant. Linezolid and moxifloxacin we have been using for ages together. So the new drugs that have been added is bedaquiline and predominant. So what is the inclusion criteria? The first criteria is patient should be above the age of 14. If the patient is less than our age of 14, we cannot give. So 13, 12, 10 years and all, we cannot give this regimen. And the next criteria is patient should not have taken the drug for more than 1 month. If previously the patient has already taken the drug for more than 1 month, we cannot give. There's one exception. If you have done a drug sense, that is your culture, you have done culture and the sensitivity pattern is documented. You know all the 3 drugs are sensitive, then we can give even if the patient is taken for 1 month. So if the patient is already taken the drug for less than 1 month, means we can give this regimen. If the patient has taken the drug, all these 3, any of the one drug for more than 1 month, we cannot give this regimen. But there is a clause. If you have the sensitivity pattern for these 3 drugs can be only got via your drug sensitivity testing. That is via culture. You do your midget culture and the culture shows these drugs are sensitive. In that case, even the patient, if he's taken the drug, all the drugs for more than 1 month, we can give this regimen. If you don't have the sensitivity pattern, that if you don't know whether the drug is sensitive or not, if the patient has been exposed to the drugs for more than 1 month, then we cannot give this regimen. If you know the drug, all these 3 drugs are sensitive, and in that case, if the patient has already taken the drug for more than 1 month also, we can give this regimen. Next, we know bedaquiline can cause QT prolongation. We need to see the QT interval. The QT interval, what we follow is Fredericia, according to Fredericia criteria. In males, the QTC, according to Fredericia, should be less than 450. and in females, it should be less than 470. It can be easily calculated. In the further slides, I'll let you know how to calculate this. So as of now, in males, the ECG QTCF correction, according to Fredericia, should be less than 450. Then only we can give this regimen. And if it's in females, it should be less than 470. Then with regards to female, they should be non-lactating. If they are lactating, they should not be breastfeeding. Only in non-pregnant women, we can give this regimen. If the patient is pregnant, then they should be willing for termination of pregnancy in order to be eligible for the regimen. If the patient is going to continue the pregnancy, we cannot give this regimen. Or if the patient is going to breastfeed, we cannot give this regimen. They'll be ineligible for this regimen if they are either going to be carry on with the pregnancy or they are going to be breastfeeding. They are non-lactating, and if they are willing for medical termination of pregnancy, then we can give this regimen. If not, we cannot give this regimen. With regards to QTC interval, it should be less than 450 in males and less than 470 in females. So we'll go for the exclusion criteria. What all patients we cannot give this regimen? If the patient is less than 14 years, we cannot give this regimen. If the patient has resistance to any one drug, we cannot give this regimen, either bedaquiline, linezolid, or pitomidine. These three drugs, if any one patient has a documented resistance, we cannot give this drug. If the liver function test is abnormal, we cannot give this regimen. If the patient has severe extrapulmonary TB, such as CNS TB, spinal TB, or disseminated TB, 3 TB, we will give longer regimen only. So any neuro TB, such as CNS TB, the regimen is longer MDR, that is 20 months regimen only. If bone TB, it's a longer MDR TB. Your pot spine and all, longer MDR TB only. If it's disseminated, it's more than one place, it's longer MDR regimen only. We will not give the shorter 6 months or 11 months regimen. And if the patient has significant QT interval, that is more than 450 in males or more than 470 in females, baseline itself, we will not give this regimen. So less than 14 years, we cannot give. Any resistance to bedaquiline, linezolid, and pitomidine, we cannot give this regimen. If there's abnormal LFT, we won't give. Abnormal cardiac arrhythmias, we won't give. Severe forms of TB, extrapulmonary TB, such as CNS, spinal, and disseminated. Remember these 3 TB, always longer regimen. CNS TB, your neuro TB, your spinal TB, such as spot spine, or any bone TB, or disseminated TB will only go for a 20 months longer regimen. Shorter regimens of 6 months and or the 11 months regimen will not be given. These are the exclusion. These patients you cannot give. See, you have 1 6 months regimen. This is the easiest regimen for this patient. So ideally, you should start with this regimen. So only in cases of these exclusion criteria, will not be able to give this regimen. Because imagine taking a drug for 20 months. But in certain cases, they will not be eligible. In that time, we don't have an alternative. So we have to go for the longer regimen. 6 months is the first regimen. This should be your first regimen for MDR-TB. Remember 4 drugs. At least this you remember. It's a 6 months regimen. We should be only given for 14 years. And it contains 4 drugs. 2 newer drugs. Bedaquiline, pitomidine, and 2 older drugs. Linezolid and moxifloxacin. At least this is sufficient. So how we give the regimen? So pitomidine is a fixed dose. 200 mg we give daily. Linezolid 600 mg we give daily. And moxifloxacin 400 mg once daily. Bedaquiline alone first 2 weeks will give us 400 mg. From the 3rd week to end of 6 months will give us as 200 mg alternate days. Monday, Wednesday, Friday will give. First 2 weeks daily 400 mg. From the 3rd week to 24th week 200 mg Monday, Wednesday, Friday alternate days. Till the 6 months, end of 6 months. These 3 drugs, pitomidine, linezolid, moxifloxacin, will be given as 200 mg OD, 600 mg OD daily, and 400 mg OD. These are the 4 drugs. Will be given for a 6 months regimen. This is the first regimen for MDR-TB. Only if the patient is not eligible, we'll move on to the next 2 regimens. Kindly note, you should know what all regimens are there, what is the duration of the drugs, and what all drugs is being given. So if by any chance, linezolid is highly toxic. So the most common side effect we see is linezolid. 2 major side effects will be seen. One is anemia, myelosuppression. Anemia we commonly see. Next is peripheral neuropathy. Patient will have burning sensation in the feet. They'll have numbness or weakness or burning sensation. So if 600 mg, if at least it should be given for the first 2 months. See, we are giving this regimen for 6 months. At least 2 months, patient should have taken the full dose. After 2 months, if the patient develops side effects, we can change it to 300 mg. We can reduce the dose. But within 2 months itself, the patient is having severe side effects. If we are not able to continue linezolid, then we have to term it as failure and go for the other regimens. So for first 2 months, if the patient is tolerating 600 mg, well and good. After 2 months, if the patient is getting side effects, we can reduce the dose from 600 to 300 mg. But if the patient in the first 2 months itself is not tolerating the 600 mg regimen, such as they develop peripheral neuropathy or anemia, in case we cannot give the regimen in the first 2 months itself, then we have to declare the regimen as failure and move on to shorter or longer MDR regimen. Okay. If the patient tolerates during the first 2 months, then after the 2 months, we can reduce the dose to 300 mg. But the total duration of the regimen will increase from 6 months to 9 months. So how we follow up these patients? The follow-up is very easy. We have to follow up via 3 things. Clinically, we should follow up the patient, whether the weight gain is there, whether it's cough, fever, or subsided or not. Radiologically, the X-ray and the lesion should be reducing. I already showed you in cavity photo, no? The cavity should be subsiding or the lesion should be, radiologically, we can either get infiltrates, consolidation. Infiltrates means it will be small dots in the X-ray. Those lesions should be reducing. And cavity means the size of the cavity should reduce. Periodically, when you assess the patient, the lesion, radiologically, the lesion should be resolving. Clinically, patient's fever should be reduced, cough should be reduced, there should be weight gain. Third is microbiologically, you should assess. Microbiologically, we should check whether the sputum smear is being converted from positive to negative. And your gene expert and all, for follow-up, gene expert and LPA should be only done during the time of diagnosis. For follow-up, you should only do sputum smear, your AFP smear and culture for follow-up. So sputum smear should be done and culture. They'll be given, all the drug-resistant TB patients will be given a chart. In the chart itself, each month they'll be given what all tests you should do. So monthly, we usually follow them on a monthly basis. And monthly, say if the patient has been started today in March, the patient has been started, in April, they will be given a date on what date they should come and what all tests should be done on that date. Each patient will be carrying a card. That card itself, the follow-up dates, what all tests should be done will be there. And what all sputum tests, blood tests, what all they should do, sputum tests, what all they should do, height, weight, and all will be documented. You just have to fill in that form and see previously from the starting date, say 21st March, we are starting the patient 24th March, 24th April, how they are. And what all tests should be done in May, June, like that for the next 6 months. What all tests should be done will be there on each month. There will be a tabular column. The tabular column, first we should give the test. And when the report comes, we should enter the report and see whether the clinical improvement is there. You should check the weight of the patient in the follow-up. Sputum status you should check. Radiological status you should check. And blood test also, if any abnormality is there or not, we should check. It will be there in the patient will be carrying a card with them. On the diagnosis itself, well, we'll be giving a card. In the card itself, tabular column will be there for follow-up. So follow-up is very easy. You don't need to buy her this and all. So we have said it's a 6 months regimen. So 26 weeks, we are going to treat the patient. After 26 weeks, they'll be followed up for, you say we start the treatment on March now. They'll be ending the treatment anywhere in September, 6 months from now. After September, they'll be followed up at 6 months, 12 months, 18 months, and 24 months. This is after September. After 6 months, next year, March, they'll be checked, follow up. This September, they'll be finishing. If they start on 24th of March, 24th September, they'll be finishing the regimen. After 24th September, after 6 months, they'll be again subjected to clinical assessment, whether there's any relapse or not. Again, after in the 12th month, they'll be checked. In the 18th month and 24th month, they'll be checked. All will be given in a tabular column form. You just need to ask the patient to come on the specified dates. This tabular column, you don't need to buy it. Now we move on to the next regimen. If the patient is not eligible for the 6 months BPAL-M, the 4 drug containing 6 months regimen, then we move to the shorter oral bedaquiline regimen. This regimen is being given to less than 13 years. We saw the BPAL-M is only can be given for more than 14 years. The patient is less than 14 years, we can give this shorter oral bedaquiline regimen. So that is a 6 months regimen. This is a 11 months regimen. So there was a study done in South Africa. Previously, this regimen contained injections such as kanamycin and amikacin. So daily giving injections for 6 months is very tiresome for the patient. So what they found out, substituting the kanamycin and amikacin with bedaquiline, they found similar efficacy. That's the evidence for starting this shorter oral bedaquiline regimen. This is a regimen for 11 months duration. So the inclusion criteria is, again, the patient should be MDR-TB, that is rifampicin resistance should be there. Then only you can start this regimen. With regards to isoniazid acid, there are 2 genes, INHA or CATG. If either one gene is resistant, you can give this regimen. If both genes are resistant, that is INHA and CAG are resistant, you cannot give this regimen. And fluoroquinolone should not be resistant to start this regimen. Okay, your levofloxacin and moxifloxacin should be sensitive. Then only we can give this. So 3 main inclusion criteria you remember. Rifampicin should be resistant. INHA and CAG for isoniazid acid, either one gene can be resistant. If both INHA and CAG are resistant, you cannot give. Either one is resistant, you can give this regimen. Either INHA or CAG, if they are resistant, you can give. With regards to isoniazid acid, rifampicin must be resistant. With regards to isoniazid acid, if one gene is resistant, you can give this regimen. If both genes are resistant, you cannot give this regimen. And if fluoroquinolone is resistant also, you cannot give this regimen. These are the inclusion criteria. The other inclusion criteria, and we have already seen, extensive TB we cannot give. So with regards to CNS and POTS pain, we cannot give this regimen. See, both neuro TB and bone TB only longer regimen. Extended duration of time you have to give the TB because the drug takes longer period to reach these sites, such as CNS and both spinal TB. And severe extensive TB, if there is multiple sites or in the lung itself, all the lobes are involved, or if there's extensive cavitation, we cannot give this regimen. So extensive disease we cannot give. Severe extrapulmonary such as CNS and bone TB we cannot give. If it's fluoroquinolone resistant, we cannot give. And if it's resistant to both the genes in isoniazid acid, we cannot give. If it's only resistant to rifampicin and resistant to one gene in isoniazid acid, we can give this regimen. This is a shorter MDR regimen. It's a 11 months regimen. So they have made a new change in this regimen. That is, linezolid has been added in this regimen for 2 months alone. So we have seen this contains an intensive phase and a continuation phase. The first 2 regimens that we saw, isoniazid monoresistant regimen and BPAL-M, both are 6 months regimen. Both doesn't contain intensive and continuation phase. Same drugs are given in the total 6 months. But with regards to shorter MDR regimen, the first difference is you have an intensive phase, you have a continuation phase. With regards to intensive phase, we have 7 drugs in the intensive phase. We have 4 drugs in continuation phase. These 7 drugs will be given for 6 months. These 4 drugs will be given for 5 months. So 6 plus 5, 11 months regimen. 6 months intensive phase, 5 months continuation phase. In the 6 months, we will be giving 7 drugs. In the continuation phase, we will be giving 4 drugs. This is sufficient. So this is a regimen we have been following. There's a new change in this regimen with regards to past 4 months. There's a new change. Linezolid is being given in place of ethionamide. Linezolid alone will be given for 2 months. In the intensive phase is for 6 months. Linezolid will get over in 2 months. Because this is a highly toxic drug, it's been given only for 2 months. The major toxicity we see with linezolid, as already mentioned, is anemia and peripheral neuropathy. And optic neuritis can also occur. So the other drugs, the rest of the 6 drugs will be continued for 6 months. The rest of the 6 drugs are levofloxacin will be continued for 6 months. Bedaquiline will be continued for 6 months. Clofazimine will be continued for 6 months. Isoniazid, this is high dose isoniazid. Pyrazinamide will be given and ethambutol will be given. So this is for MDR-TB, shorter MDR-TB. It's a 11 months regimen, 6 months of intensive phase and 5 months of continuation phase. In the 6 months, 7 drugs will be given in the intensive phase. Linezolid will get over in 2 months. Levofloxacin, bedaquiline, clofazimine, isoniazid, pyrazinamide, and ethambutol will be given for 6 months. In the continuation phase of 5 months, 4 drugs will be given. Levofloxacin, clofazimine, pyrazinamide, and ethambutol. At least remember, 7 drugs will be given for 6 months and 4 drugs will be given for 5 months. So 6 plus 5 is an 11 months regimen. So the duration is 11 months. Points notice, linezolid will be given only for 2 months. The rest of the 6 drugs will be given for 6 months intensive phase, and 4 drugs will be given in a continuation phase for 5 months. So this is the treatment extension. This is slightly will be elaborate. So the intensive phase, the shorter MDR can be either given as 11 months or 9 months also. When can we give 9 months is in the intensive phase. At the end of 4 months, they'll do a sputum smear. If it's negative, after 4 months itself, we can start the continuation phase. So then it will become 4 plus 5, 9 months regimen. But better to give it as a 11 months regimen. So you remember as intensive phase is 6 months, continuation phase is 5 months. So 6 plus 5. So additional consideration for giving bedaquiline is bedaquiline should be given above the age of 5 years. So that's why we are giving for less than 13 years also bedaquiline can be given. So bedaquiline causes QTc interval prolongation, QT prolongation. So how to calculate the QT prolongation? So if you take an ECG, in the ECG itself, we get a QT interval. You can see This QT interval will be marked in the ECG. You can get various calculators. You can go for corrected QT in the there are various calculators available in a mobile app itself. In that, you have to select Fredericia. In that, if you put the QT interval and the heart rate of the patient, based on that, we can calculate the QTC interval according to Fredericia scale. We have 3 formulas, corrected QTC. Fredericia formula alone, this one is taken in the guidelines. So in order to see the QTC corrected according to Fredericia, the simple method is to take the QT interval in the ECG that you are taking. The QT interval, the value will be entered. Enter that in your mobile app and select the Fredericia formula and fill in the required forms, and you will get the QT interval according to Fredericia, corrected according to Fredericia scale. That value should be less than 450 in males and less than 470 in females. Then only we can give bedaquiline. So this is how the weight band is calculated. Again, we have seen we have 7 drugs in intensive phase. Again, in the continuation phase, this will be all the 7 drugs will be given for linezolid alone will be given for 2 months. Rest of the 6 drugs will be given for 6 months duration. If the patient is again say 40 kg, we'll be giving the second weight band. If it's 50 kg, we'll be giving the third weight band. So if say again 50 kg, we'll be giving high dose isonic acid of 900 mg, ethambutol of 1200, pyrazinamide of 1750, leoflox of 1000, bedaquiline dose is standard, tofacitinib of 100 and linezolid of 600. All patients due to peripheral neuropathy, we add pyridoxine according to weight band. So this is the shorter MDR regimen. We'll be giving 7 drugs. Linezolid alone will get over in 2 months. Rest of the 6 drugs will be giving for 6 months. In the continuation phase of 5 months, we'll be giving only 4 drugs. This is the weight band according to which we'll give the regimen. Certain drugs are safe during giving this MDR regimen. With regards to anti-emetics, metoclopramide is safe to use. We cannot give domperidone or emised, ondansetron. So this chart I have given, you can go through what all painkillers you should give, what all antacids we should, what all safe and what all not safe is. We have this drug chart while giving MDR regimen. So replacement sequence in this, if one drug is patient's not, we've seen we are giving 7 drugs. If the patient's not tolerating 1 drug, we can continue with the rest of the other drugs. If the patients are not tolerating more than 1 drug, we cannot give this regimen. We have to shift over to the longer regimen. Or if the patient is resistant or intolerant, the patient is developing side effects or developing resistance to any 1 drug, we cannot, more than 1 drug, we cannot give this regimen. We have to go for the longer, from 11 months regimen, we have to switch over to the longer 20 months regimen. Follow-up, as again told, patient will be handed over a chart, clinical details, radiological details, X-ray details, sputum smear and blood investigation. Everything will be there monthly wise or in the required terms. Patient should come under regular intervals. And based on the follow-up, we'll see in the printed chart, we just have to give that patient the necessary test. When they come with the reports, we have to enter it and see whether the patient is improving or not. So this is a follow-up chart. This can be given in the, handed out to the patient itself. With regards to follow-up, we'll be seeing the sputum smear and culture. Both should be turning negative. Both your sputum smear AFP and your midget culture should turn up negative with as the patient is taking the treatment. If in between, if it shows positive, then you have to refer it again, see if the patient is not tolerating the regimen or not. So other blood monitors should be checked periodically. It will be given up in the follow-up chart. So with regards to HIV patients, we see they should be started on the MDR. They can be given both the shorter and the longer MDR regimen. So BPAL-M also can be given. There are certain drug-drug interactions. So moxifloxacin and clofazimine have drug toxicity with the ART drugs. We now are not giving efavirenz and ritonavir cannot be given. So we preferably give ART dolutegravir now. With the ART, we give dolutegravir based regimen to these patients of MDR-TB. Certain drugs, they were ART drugs, patients will have drug-drug interaction with their MDR regimen. The common drugs are efavirenz and ritonavir and zerovidin. All these drugs are avoided. With regards to role of surgery, if the patient has a limited disease and if the sputum smear is negative, or if the patient is recurrently getting TB positive, there's a role of, you can go for either segmentectomy or lobectomy or pneumonectomy if the patient is having the localized disease, or if the patient's bacteriological conversion is not there, patient is recurrently coming up with smear positive, or if there's a high chance of relapse, or if the patient is having any extensive parenchymal destruction such as hemoptysis, bronchiectasis, bronchopleural fistula, or empyema, there's a role for surgery. renal dose adjustment are given. If the patient is a CKD patient, certain drugs you don't need to adjust the dose, such as isoniazid, moxifloxacin, ethionamide, bedaquiline, you don't need to adjust the dose, clofazimine and all, but pyrazimide, ethambutol, levofloxacin, you need to adjust the dose for CKD patients. Pre-existing liver disease patients, if the value is beyond 3 times normal, we cannot give the shorter MDR, we have to go for longer MDR regimen. Because most of the drugs in the shorter MDR are hepatotoxic, we cannot give this drug for the pre-existing liver disease patient. High dose isoniazid and levofloxacin that we give in this regimen, moxifloxacin, and are associated with psychosis. If the patient develops psychiatric symptoms, we can consult with the psychiatrist and start antipsychotics. If the patient cannot continue the regimen, then we need to again shift over to the longer regimen. If the patient cannot be, in spite of giving antipsychotics, the patient is having symptoms, then with the opinion of the psychiatrist, we shift to longer regimen. There are various side effects associated with each of the drugs. The common side effect is QT prolongation can be seen along with bedaquiline. Then we can get gastrointestinal side effects such as bloating, acidity we can have. Then we can have any skin itching, or we can, with regards to clofazimine, causes darkness of the skin. Patient's skin tone will get dark. Then they have metallic taste. Linezolid is highly toxic, both causes anemia and peripheral neuropathy. Given what all drugs common side effects, based on it, we need to give measures to reduce the toxicity. We can either give nutritional supplements or we need to replace the drug according to if the side effects are very severe. So what all condition we cannot give shorter MDR is severe extrapulmonary such as CNS or port spine, disseminated disease we cannot give, intolerance or resistance. If the patient is not tolerating one drug or having severe side effects or known resistance to more than one drug in the shorter MDR, we have to shift over to the longer MDR regimen. Or the patient is already exposed to any one of the drugs. If the patient is already taken the drugs, we cannot give shorter MDR and we have to only go for the longer MDR regimen. So longer MDR regimen, I already told, it's a 20 months regimen. We take 3 drugs in group A, levofloxacin, bedaquiline, linezolid, clofazimine, cycloserine. So, and 2 drugs in group B. Group A, all the 3 drugs we take. Group B, we have 2 drugs, clofazimine and cycloserine. With this 5 drugs, we form the regimen. If you're not able to use any one drug due to any known side effect or patient intolerance or patient resistance to any one drug, we replace it with group C drug. Any one drug, if you're not able to use from group A or group B, we substitute group C. So levofloxacin, bedaquiline, linezolid, clofazimine, 3 group A drugs, clofazimine and cycloserine are group B. These 5 drugs you remember. Group A, group B you remember. If you're not able to form a regimen with this, we go for group C. So the long oral regimen is a 20 months regimen, preferably given to patients who are extensive disease or CNS or orthospine disease or disseminated disease, or who have any drug resistance or intolerance, who are not eligible for the 6 months BPAL-M or shorter MDR, we give for the 20 months. Remember, 20 months is a very long duration to take, but in certain situations, this is the best regimen. So 6 months we give bedaquiline, levoflox, linezolid. LL you remember. Levofloxacin, linezolid. CC, clofazimine and cycloserine. Bedaquiline is the newer drug. Levoflox and linezolid are the older drugs. 2LL, 2CC, easy to remember. These 5 drugs we form the regimen 6 months. After 6 months, bedaquiline will get over. LL, levofloxacin, linezolid, CC, clofazimine and cycloserine. This we continue for 14 months. So 6 plus 14, 20 months the regimen is over. So 3 drugs from group A. Bedaquiline, levoflox, linezolid group A. Group B is clofazimine, cycloserine. Bedaquiline alone will get over in 6 months. This is the intensive phase. This is the continuation phase for 14 months. So this is sufficient. So bedaquiline, the dosage is 400 mg for OD for 2 weeks, followed by 200 mg thrice weekly. Dilaminate, there's another newer drug. It's given as 100 mg BD. This is a group C drug. These are the new 2 drugs that has been approved. This you should know. Replacement sequence according to guidelines is, say we have taken 3 drugs from group A and 2 drugs from group B. If you're not able to give any one drug, we should substitute from group C. This is the replacement sequence. Dilaminate first, amikacin next, pyrazidamide next, ethionamide. In this order, whichever patient can tolerate will be given. So if any one drug cannot be given, we'll be substituting from group C. So the standard regimen or drug sensitive regimen is 2 HRZE followed by 4 HRZE. This is the drug sensitive regimen. The other 3 standard regimens are isoniazid monoresistant regimen is simple, same as your HRZE regimen, but no intensive or continuation phase. You give 6 months of isoniazid resistant, you replace it with levofloxacin. Rest of the 3 drugs are same. Rifampicin, ethambutol, pyrazidamide. 6 months of LRZE. Shorter MDR is your 6 plus 5 months, 11 months regimen. Longer MDR is 6 plus 14 months, 20 months regimen. In addition, we have a newer B-Pal-M regimen, that is 6 months regimen. These three are MDR regimen. Your shorter 11 months, 20 months, and 6 months B-Pal-M are MDR means rifampicin resistant. This is isoniazid monoresistant regimen is 6 months. Again, drug susceptibility this is drug sensitive TB. Always look for 3 things. Clinically, the patient should improve. Microbiologically, sputum from smear and culture should be from positive to negative. Radiologically, the lesion should be resolved. All 3 must be improving. Then only you should be reducing the. You should know there's a NICSHA ID. The NICSHA ID, all the patient details will be entered according to Aadhaar. If you put the NICSHA ID from the starting, see, longer MDR is 20 months regimen. In the entire period of 20 months, all their patient records will be entered in the NICSHA ID. All their sputum reports, radiological improvement, the initial sputum status, initial gene expert, culture, each month what all sputum they do should be entered in the NICSHA, so that if you just put that ID, you can see the entire duration 20 months, what all the patient. Then only we can assess in between if the patient is going for failure. Say after 9 months, if the sputum smear is turning up to be positive, then means the treatment is failing in the midway. So all this can be tracked via your NICSHA ID. It's a long regimen. The shortest 6 months itself is a long duration for a patient to take a regimen. So always be psychologically aware. It's a trauma for the patient. No, none of the TB patient will tell their relatives or friends that they have TB. It's a psychological trauma. Be sensitive when you're handling a TB patient. Psychologically support the patient. Then only they will complete the treatment. See, it's not a single disease. If he's going to cough, it's going to go around the community. It's going to spread around to everybody. Somewhere, even if someone known to us can acquire through them. So always give a psychological support so that they finish the treatment, so that it's good for the patient and for the community also. So this is the isoniazid monoresistant 6 months regimen. 4 drugs, 6 months. Here I've given how to follow up the patient also. What are the weight band? According to the weight band, you can easily frame the regimen with this. This is isoniazid monoresistant. For MDR is rifampicin resistant. We have the 6 months B-Pal-M regimen. Accordingly, 6 months will be giving 4 drugs only. Here also 6 months no intensive and continuation phase. 6 months 4 drugs. Isoniazid monoresistant. Here also 6 months 4 drugs. Bedaquiline, pretamine, new drugs, linezolid, moxifloxacin, old drugs. We give for 6 months. No IP or CP. Shorter MDR has an intensive phase and continuation phase. It's a 11 months regimen. 6 months we give 7 drugs. In the continuation phase, we give 4 drugs. Here also longer oral regimen is 20 months regimen. 5 drugs we give in intensive phase. 4 drugs. Here also continuation phase same. 4 drugs only we give. 3 drugs from group A, 2 drugs from group 3 drugs from group A and 2 drugs from group B. We fill the regimen. So weight monitoring, the newer treatment, the newer drugs with bedaquiline, delamanid, and pretomanid, we are seeing the success rate of the patients much more than the older DRTB regimen that used to have. The government has been giving the drugs that the government is giving it free of cost in the government, and these are very costly medicine. They cost lakhs, but the government is giving these drugs in order to save the life of the patient, and TB transmission should be eliminated in the community. So to summarize, please suspect drug-resistant TB patients diagnosed in every possible situation. Use only WHO and the government approved protocols. Treat the diagnosis should be based on the approved protocols. As of now, whole genome sequencing is not approved. Don't base your treatment based on whole genome sequencing. You can keep it for a follow-up or your reference, but don't base it for treatment. Treat with approved protocols. Patient will have side effects with this. Manage side effects. Manage comorbidities, diabetes or whatever comorbidities patient have, treat that also accordingly. All diabetes should be properly treated. Counsel all the patients for better compliance. Also, the patients' attendants also counsel them for better compliance in order so that they complete the treatment. Always notify. TB is a notifiable disease. You should know what to write. You should know whether in the case sheet, if you are writing, write always a 3 parts: drug sensitive or not, pulmonary or extra pulmonary, clinically diagnosed or microbiologically confirmed. Or write all these 3 parts. And then give proper regimen. There is a standard regimen. All TB cases should be notified. Government will have a track record. So whatever you write in the case sheet will be going in the, or in the discharge summary, what you're writing will be followed up with the government also. It's a notifiable disease. It should be notified to the government. Look for 3 things: clinical improvement, radiological improvement, and microbiological improvement. The most, I see close to 50 cases. I work in a TB center for the past 9 years. I see close to 50 cases per day. You know who's the most severe TB case who I saw? It was a postgraduate, pediatric postgraduate, around 25 years. She had tuberculosis in the lungs. She had cervical lymph node. She had pot spine. She had abdominal TB, nodes everywhere in the abdomen. As healthcare workers, we are the most prone for tuberculosis. always have a good protein diet. Take care of your diet. Don't take high carbohydrate or junk food. Have a good diet. A lot of time you will not be able to take your food on time. At least whenever you're having the food, take a good high protein diet. Make your health a priority. Keep your BMI in check. Have a good quality of sleep as much as possible. All our healthcare workers are prone for tuberculosis. Only if we keep ourselves healthy, we can take care of our patients. This will be the take-home message. Thank you. Let's diagnose TB earlier. Let's treat them according to proper diagnostics and standard treatment protocols. Thank you. I'll be able to...
Yes, sir.
Yeah, if any questions is there, we can take it now.
Yeah, sure. Thank you, sir. It was actually both lucid and exhaustive.
You have break down all the complex guideline into simple slides, and most of the questions which were coming, you already answered in the subsequent slide. So there are few questions, and one of the question is, isoniazid resistant is associated with or cross-resistant with ethambutol, which is not detected in LPA. In such cases, what should be the regime for isoniazid monoresistance?
No, see, isoniazid resistance associated with cross reaction with ethionamide. So for isoniazid monoresistant, regimen is only, we are substituting isoniazid with levofloxacin. So for INH monoresistant, it doesn't matter. You're not going to give ethionamide in the first place. In shorter MDR regimen, it becomes a problem. If in shorter MDR regimen, if isoniazid is resistant, we have to ask which gene is resistant. If INH-A gene is resistant, then ethionamide cannot be given. So there are two genes for isoniazid. One is INH-A and other is CAT-G. What the guideline says is, if both are resistant, you cannot give shorter MDR regimen. If either one is resistant, then you can give shorter MDR regimen. That is one point to note. If isoniazid, both the genes are resistant, you cannot give INH monoresistant regimen. That is 6 months shorter MDR, you cannot give. You have to go for longer MDR regimen. If one is resistant, INH-A gene is resistant, then it is associated with ethionamide resistance. Then we can go for, then you have to know that if INH-A gene is resistant, ethionamide is also resistant. That is the cross-reactivity pattern. But now in shorter MDR also, they're not giving ethionamide. They replace it with linezolide. So if INH-A gene is resistant, also not an issue. Only thing to notice, if INH-A is resistant, ethionamide is also resistant. That you can keep in mind. Otherwise, it's not of much practical use.
And another question is, sir, patient who are MDR-TB associated with HIV, and how do we go about it? Like, what should be given priority to treat the patient?
No, we should start simultaneously. First, ATT will be started. Side by side, we'll start with the ART also. Certain drugs are known to cause, certain ART drugs are known to interact with our drug-resistant TB regimen. So, ART medical officer will most probably start in a dolutegravir-based regimen.
Okay. So, another personal question, sir. Like,
Yes.
as you said, most of the healthcare workers who are diagnosed, they are MDR-TB. So, what is your experience around, like, out of all the MDR-TB, how many % were healthcare workers?
So, when compared to the general population, I say around 10% of the healthcare purpose. See, if you have 100 in a batch, I'd say closely anywhere between 5 to 10% will be getting affected. We all will be carrying the infection within us. We'll get exposed invariably if you're going for clinical zones. Infection is different, disease is different. It will turn up to a disease once your immunity is getting low. So we should make sure we don't develop diabetes, or we should have a regular screening for diabetes for ourselves first. We should maintain a good BMI, should take a high protein diet. Yeah, I know our professor, he never wears a mask for a drug-resistant TB. What? He's been working for 30 years. He's the inspiration. That's why he didn't get TB, so I won't get a TB. That's the assumption. But he used to have high protein diet. So you make sure you have a good diet, make your health a priority, and have your BMI in control. He used to walk for 2 hours daily. So I also make sure, at least if you keep your health as a priority, if you keep your BMI in check, if you have a good diet, TB won't come. Even if you have the infection, it won't turn into a disease. And secondly, we should monitor ourselves with a health screening at least. Yearly once, at least do a basic once in 2 years or 3 years, get a CBC, LFT, RFT, and then sugar done for healthcare workers. Okay. And if you're going for another thing is, those who are taking up for surgeries and all, take a chest X-ray and see there's no active TB. If you're taking a closed room with an AC room, if you're going to have an active TB, then the chance of you occurring is much more.
So just to add on to it, one of the participants is asking why high protein diet prevents tuberculosis.
No, basically immunosuppression is the main cause for infection turning up to a disease. So protein diet in turn is known to have restore our immunity better. So even with diet for any TB patients, the government is providing for drug sensitive patients, the government is providing 500 rupees on a monthly basis to improve the nutrition. Even if you give the drugs, the patient's not taking high protein diet, then there is a chance of failure. For drug resistant TB patient, the government is providing 1,000 rupees for nutrition. So once if your immunity is better with the protein diet, it helps to regain your immunity better.
Thank you very much, sir. And we have few more questions which can be answered through messages. So
Sure.
we'll end the session here and we'll move on to the next session. Thank you very much, sir.
Thank you so much for the opportunity. Thank you.
Thank you so much, sir. So we conclude with the sessions. All the participants of video and poster presentation be eager to listen to your results. I request Dr. Girish, who was one of the judge for the poster presentations, to announce the results of the competition.
Out of 34, 18 was screened for primary. It is there. Michelle. Sure. One kilometers.
So we have come to the end of today's CME. A major part of this CME was the posters we received from various parts of the country. A total of 34 posters were received, and there was a primary screening after which 18 posters were shortlisted for online presentation, which happened virtually on 22nd March from 11 AM onwards. Myself and Dr. Satyanarayana were the internal and external judges respectively. Interestingly, the posters were all well prepared, and by presentation was also very good. But some of them were case reports directly, giving the details of a particular case, which were also evaluated on the basis of the clarity of presentation, the importance of the particular case, and the follow-up as well. So the judges unanimously elected Dr. Isha Kumar's presentation. She is a postgraduate from AIMS Bhubaneswar. So all these are participant posters. I'll just focus on Isha's presentation. Yeah, the third poster. The third poster titled Detection of Mycobacterium tuberculosis Positivity and Rifampicin Resistance in Extrapulmonary TB cases by using expert MTB rifampicin assay. A very simple study basically, but it highlights the importance of picking up extrapulmonary TB cases, which is actually hidden part of the iceberg. We have focused on pulmonary TB for a long time, and we have definite strategy towards ending that. But the extrapulmonary TB also requires a lot of attention. Many a time it's misdiagnosed, underdiagnosed, and untreated as well. And she had made a very simple study, and her outcomes were also good, and her presentation was also good. So the first place goes to Dr. Isha Kumar from AIMS postgraduate. Second was
Skips.
Yeah, second place. Yeah, second was actually very interesting study by Dr. Raksha Bhatt. In fact, if this study was presented after doing the complete workup, because this is a pilot study which was presented to us, a very interesting topic, all of you will agree with me. It is artificial intelligence which meets TB diagnostics and unlocking the potential of the ChatGPT 4 version in Gene Expert Ultra interpretation. And the specimens were all respiratory specimens. So it was focusing on the pulmonary TB. An interesting part of this is a evolving study. Further needs to be elaborated beyond the pilot study level, including many samples or many patient samples, and defining the large language modules of ChatGPT, whose version itself is increasing now, improving for a period of time now. So we had suggested her to further, increase the patient specimens and also the outcome, because it needs to be sort of validated by non-microbiologists for the benefit of the patients. So a very good study. So the second prize goes to Dr. Raksha Bhatt. The third prize was for Dr. Preetham Singh. He is a postgraduate from Department of Microbiology, Subhati Medical College, Meerut. It's on mutational pattern analysis of MDR-TB by LPA, line probe assay. An interesting part of this study was obviously the detection of the mechanism of resistance in MDR-TB, primarily by mutation. They employed a huge sample size. That's the plus point of this study. And it was worked up with a very good assay available for MDR detection, which is LPA. Only limitation we found was not extended for second line drugs. It was only for the first line drugs. So we suggested him to do further study on this to detect the extent of the mutational resistance available for MDR-TB. So the third prize goes to Dr. Preetham Singh. So after this, we had received the other almost 15 presentations. All were good, but needs further studies or change in methodology, etc., which we are suggested. Thank you all.
Thank you, sir. So as we had seen in the beginning of our CME, we had displayed few of the videos we received for the competition. I have, we call Dr. Santosh Machado, Assistant Professor, to announce the results of video competition.
Good afternoon, everybody. So we had a TB awareness video campaign for our local staff. So we received 6 videos. It was judged by myself, Dr. Santosh, and Dr. Pragati from Community Medicine. So these are the winners. So the third place goes to Varsha and team. The second place goes to Manjunath Prasad and team. And the first place goes to Kirtana and team, Kirmita and team, sorry. So they had nicely used puppets to convey the message. So well done.
Thank you, sir. As we come to the close of today's event, it's my pleasure to invite Dr. Supriya, Assistant Professor, to express our gratitude on behalf of everyone here.
Good afternoon, everyone. It's my pleasure to propose a vote of thanks on this occasion. I, Dr. Supriya, on behalf of the Department of Microbiology, expressing our sincere gratitude to all who contributed to the success of this CME conference. First and foremost, we extend our heartfelt thanks to our Chief Patron, Dr. D.A. Kalpaja, Medical Advisor, Dr. Mahesh Babu Kotapalli, Principal, Dr. Sridhar Venkatesh, MS, Dr. Uma Maheshwar, and MSc Chairman, Dr. Geeta Narayan. We also express our profound gratitude to the speakers, Dr. Rashmi, Dr. Vaijantimala, and Dr. Devanathan, for gracing us with their presence and sharing their valuable insights. A special thanks goes to all the volunteer staff members, ISD, and administrative team for their generous support. Finally, we extend our appreciation to each and every participants for your active participation and engagement. Your presence and contribution have made this conference a truly enriching and memorable experience. And we will also look forward to seeing you at our next CME conference. Thank you.
Thank you, Dr. Supriya. Tuberculosis remains a global health challenge, but through continuous education, research, and collaboration, we can work together to reduce its impact and save lives. We encourage you all to apply the insight gained today in your practice and continue to fight against TB. Myself, Dr. Elizabeth, and Dr. Prashant, the whole and soul of today's event, thank you once again for the active participation. Yes, we can end TB. Commit, invest, deliver. Thank you.
Thank you.